Hi, good afternoon, everyone. The topic of today's presentation is immediate complete. The learning outcomes expected of you are you should be able to define immediate dentures. You should be able to select a patient which is ideally suited for making immediate dentures. You should be able to compare between different types of immediate dentures, that is immediate dentures, interim dentures, JIFFY dentures, etc. You should be able to formulate a successful treatment plan for such patients, and you're also expected to manage the post-insertion maintenance of immediate dentures. Now coming to the introduction, following the extraction of remaining dentition which cannot be rehabilitated, the patient suffers social indignity, functional difficulty of going out without teeth for several weeks. In such situations, an immediate dentures is considered the best choice when the last hopeless teeth are to be removed, so that the patient can be spared needless embarrassment of having no teeth at all. Now it offers several advantages as it protects the surgical site as a bandage, and it in appearance is excellent because the natural teeth serve as a guide for positioning the future denture teeth. But making an immediate denture is quite challenging when compared to a conventional CD, as a trying stage is not possible to verify the arrangement of the artificial anterior teeth. Now, the GPT-8 defines immediate dentures as any removable dental prosthesis fabricated for placement immediately following removal of natural teeth or tooth. According to Fenn, immediate denture is a denture constructed before extraction of teeth, which it replaces and fitted immediately after the teeth are. Now, conventional, there are different type of immediate dentures. The first one is the conventional immediate dentures, which is done after placement of immediate denture. It is relined and fitted to serve as a long-term process. So once immediate denture is made, it may be relined after say 6 months or 1 year to serve as a conventional complete denture. Secondly, you have interim immediate dentures. These type of immediate dentures enhance the aesthetics, stabilization and function for a limited period of time. After the interim period of say healing of 3 to 4 months, these dentures are then discarded and conventional complete dentures are then fabricated for such patients. Now coming to one such type of immediate dentures which is known as JIFFY dentures. JIFFY dentures or JIFFY is an English term which means anything which is done in a hurry or which is done quickly. These type of intermediate dentures are used to be replaced by a conventional complete denture later on. Say during the healing period, you fabricate a JIFFY denture, and after a period of 3 to 4 months, when the complete healing has taken place and the residual ridges are remodeled, you construct a definitive conventional complete denture. In these type of JIFFY dentures, either the denture teeth are made of tooth colored acrylic resin, as you can see over here. Patient's existing denture or existing teeth impression is taken, and this impression is then filled with cold cure tooth colored autopolymerizing resin, or we can also use patient's existing teeth after extraction to fabricate a JIFFY. So here is one such case in which the patient has a long span bridge extending from 17 to 16 to 26, and these teeth were considered unsalvageable and he was indicated for extraction. As you can see, this is a long span bridge with only three abutments, that is 1626 and 1 3. So in such cases, an impression was taken in this case with the prosthesis in the mouth, and then after extraction the process was replaced in the impression. The abutment copings were then blocked out with modeling bags, and then a stone model or dental stone model was then poured over it. Later on, the flange areas, that is the buccal and labial and the palatal flange areas of the denture, were then processed with cold cure autopolymerizing acrylic resin, and in this way a JIFFY denture was constructed. So this will serve as an interim denture during the healing period. Now coming to the indications of immediate dentures. Immediate dentures essentially are constructed when all the remaining dentition of the patient is considered non-restorable, either due to advanced periodontal disease or due to severe caries conditions, and patient may have systemic diseases as uncontrolled diabetes. In such cases, we have to extract all the remaining hopeless teeth and construct an immediate denture. Now coming to the contraindications are when we have an uncooperative patient, patient with poor general health, patient in which there may be multiple extraction could be a risk and can result in systemic complications, such as patient on uh, anticoagulants, patient with uncontrolled diabetes and other systemic diseases like hypertension and thyroid toxicosis, and or with any other systemic diseases. Also emotionally disturbed individuals which may have an underlying psychological condition. In such cases also immediate dentures are considered to be contraindicated. The advantages, as I mentioned, were there is no edentulous period as the dentures are constructed prior to the extraction of the anterior teeth of the patient. So there is no trine. Directly after jaw relation, the dentures are fabricated, and at the day of the extraction, the dentures are immediately inserted post extraction. There is circumoral support, there is no loss of muscle tone or vertical dimension of occlusion, and face side, all these things are maintained because there is no period of edentulous. There is no risk of alteration of the tongue size, as again there is no edentulous period, because in a conventional complete denture, if the patient has been left edentulous for a long period of time, say 1 year, like that, this can result in enlargement of the tongue and can result later on in difficulty in placement of teeth in the ideal position. There is less post-op pain because the immediate denture acts like a bandage or a scaffolding over the extraction site in the anterior region. It is easier to duplicate the natural tooth shape, anatomy, the rotation, position, etc. for the immediate denture if that is what the patient wants. It is more easily for the patient to adapt because there is no period of edentulousness. Immediately, patient gets acclimatized to the new denture. Speech and mastication are rarely compromised. Correction and refinement of the dentures can be done at a later stage. Say, if you have fabricated an immediate denture, it can be done a few months, 6 months down the lane, or 3 to 4 months down the line after the construction of the immediate denture. There is also a psychological benefit because the patient does not have to be edentulous, so his dignity is maintained and preserved. Now, disadvantages are the anterior ridge undercut areas. They may interfere with the impression procedures and with the insertion of the dentures at the denture fitting appointment. Presence of remaining teeth in different positions may lead to incorrect jaw relationship or incorrect recording of the centric relationship. There is no trine stage, so you cannot ascertain how the denture teeth will look after the fabrication of an immediate denture. Are they providing sufficient lip support? Are they is there will they result in any increased vertical dimension? All these things are difficult to ascertain, and since there is no trine stage, or more chairside time is involved during all the procedures, especially during denture insertion procedure. There may be temporary impairment of speech and mastication immediate post placement of the denture, but this is very negligible and should not be considered a disadvantage. Bone resorption and shrinkage of the unhealed soft tissue is greater and faster and may require frequent relining. So frequent relining is essentially required after the fabrication of an immediate denture or a intermediate denture. You need to reline it with tissue conditioners and soft liners frequently for a few months. And then coming to the diagnosis, treatment planning, and prognosis. Now, scrupulous treatment planning and patient education plus meticulous clinical performance aided by careful use of tissue conditioners will ensure a predictable treatment outcome. With a well-planned monitoring and modification of the conventional immediate denture, can become a definitive process for long-term wear. So if when you're fabricating a classic immediate denture, then later on it can be relined at a period of 6 months or 1 year post fabrication of immediate denture, and then can be converted to a conventional complete denture. So economically also it is of benefit to the patient, as patient does not have to fabricate a new processes, but like I said, the execution, the planning, and the fabrication of the immediate denture should be such that it would not cause any complications later on. Now, coming to the clinical and laboratory steps involved, first visit inevitably the extraction of any posterior teeth. So in such cases, if here you can see patient has anterior as well as posterior teeth in the maxillary arch, and on the right side on the left side on the mandibular arch. So first, the posterior teeth, that is the bicuspids and the molars, need to be extracted with the exception of the anterior teeth. The anterior teeth we will usually retain until the denture insertion appointment. Okay, so first the posterior teeth will be extracted as shown here. Oral prophylaxis will be performed. If the patient has any other soft tissue conditions like candidiasis or dental irritation hyperplasia from poorly fitting removable partial denture or RPD, that needs to be treated. And if any other procedures need to be performed, then they should be performed at this stage. That is, this is a sort of a mouth preparation stage before the steps for the fabrication of an immediate. Then immediate primary impressions are taken of the both upper and lower arches. A bite registration can be done using wax or using a bite registration material. If the patient has already missing posterior teeth, then we can record a bite registration with a upper and lower distal extension wax rims. or record basis. So then after that we will take a custom impression or a final impression for such patients before the extraction of the anterior teeth. So the tray in such cases is a similar tray to what we will fabricate in a conventional complete denture patient. We fabricate a spacer with stops on the teeth as well as tissue stops, so that we can take a selective pressure impression technique. Again, the borders will be 2 mm short of the reflection of the mucobuccal vestibule. You will provide adequate relief for the labial and the buccal freedoms and the mid-palatal raphe and the incisive. Once all these blockouts are done, the spacer is fabricated with the stops, and the special tray or custom tray is fabricated over with autopolymerizing acrylic resin or LC. Okay, so we can also fabricate two trays or a sectional tray in which one tray covers the teeth, another tray covers the edentulous area, as can be seen over here. So this is a Campagna technique in which first a custom tray is fabricated covering all the denture bearing or dental basal seat area, including the label and the buccal flanges, and then only the teeth area is left out. A window is carved into it and border moldings are done, and a final impression is taken with zinc oxide dugenol or a monophase type of rubber base impression material, and then a second pickup impression is taken with alginate or again a rubber monophase rubber impression material in a stock tray or in a second custom tray. So this is essentially a pickup impression of the teeth over the impression of the denture basal seat area. Okay, so this is one type of technique. In another technique we can have two different trays, that is two sectional trays. One tray covers only the distal extension area where the posterior teeth have already been extracted, the healing has taken place, and we do the border molding and the secondary impression of the posterior area, and over this we take alternate impression in a stock tray. So the essentially the first impression is picked up in a stock tray with the alginate along with the impression of the anatomical form of the teeth. So this is again another case showing a similar approach using two sectional trays, one for the denture bearing area and another for the any remaining anterior teeth, which are picked up in a stock tray or in a separate sectional custom tray as seen over here. So in some cases where the remaining anterior teeth are severely parodontally compromised and you fear that during the impression the teeth may come out, you can first stabilize such teeth with a white registration material. That is, you inject white registration material over these teeth and interdentally in between these teeth, and then you take a pickup impression in a custom tray. After this, so this white registration material will protect these teeth from getting pulled out at the time of the second impression. So after the second impression, what is left out is the jaw relationship. So in jaw relationship, the procedure for jaw relationship is same. You will fabricate denture bases or record bases with autopolymerizing acrylic resin or LC light cure resin, and then you fabricate wax rims over it. Since we retain the anterior teeth till the last appointment, we will fabricate denture bases with wax rims on the posterior edentulous areas, and then the vertical dimension and the horizontal jaw relationship is done. We can also take orientation jaw relationship into consideration using a Facebook transfer for mounting on the articulator. So here we have the final master cast. Beaded and bordered beaded impressions are then poured, and we have the final master card. Any undercuts are blocked out, and using a autopolymerizing acrylic resin and modeling wax, we fabricate the record bases or the wax rims. Okay, then the jaw relationship is done in the conventional way how we do for complete dentures, and then the denture teeth setting is done. That is, for the anterior teeth are removed from the cast or knocked out from the cast, and the teeth arrangement is done for the anterior and posterior teeth together as we do in a complete denture. So here we can see that we have a few of the anterior and a couple of posterior teeth remaining, which will be knocked out from the cast, and then all the teeth will be arranged, that is 14 teeth per hour, just like we do for a conventional complete denture. So all the considerations such as the label fullness, cheek fullness, the smile line, and overjet, overbite, all these things are considered similar to how we fabricate conventional dentures. So we can see here, using a jeweler's saw or using a micromotor, we can trim or knock off the remaining teeth from the cast. There is a specific pattern in which these teeth need to be removed. The teeth are removed in such a way that they will resemble a healed extraction socket. So generally, the label part of the extraction socket or the teeth area is divided into three parts, that is cervical, middle and the coronal. And then a three plane reduction is done on the label side, because on the label side the bone resorption will be more, whereas on the palatal side there is only one plane reduction is done, as the palatal bone will not resorb much. So we can see here, first the teeth are knocked off from the socket, then depressions are made where the teeth root will be there, and then the label flange or the label part of the socket is divided into three parts, that is, and it is reduced into three planes as seen over the in the figure over here. And the palatal mucosa is just rounded in one plane, as we don't expect much resorption to take place on the palatal aspect. So after that, the remaining teeth, anterior teeth, are set just like you would set in a conventional complete denture. And then the denture is flasked, it is dewaxed, and then it is invested, and then after curing, the denture is finished and polished just like you would in a conventional complete denture. Okay, so after this, at the surgical visit, we will fabricate a surgical template on the duplicated master cast after removing all the anterior teeth. So basically, surgical template is a clear acrylic or the vacuum formed template which is adapted onto the duplicated master cast after the extraction of the teeth on the master cast. So this surgical template will serve as a guide during extraction and enveloplasty of the teeth just before the insertion of the immediate denture. So you can see this is the autopolymerizing clear resin surgical template fabricated, and after the extraction this template is placed over the extraction sockets to see any pressure areas, and then alveoloplasty can be done and excess tissue can be trimmed over here before the denture is inserted in the patient. So we can also fabricate it using vacuum formed 2 to 3 mm thick polyethylene sheets. So this is the finished and processed dentures. Again, denture insertion appointment is similar to conventional complete dentures. However, in immediate dentures we need to preserve any undercuts, and the flanges need to be thick, as the undercuts will aid in retention of the dentures, and the flanges can be trimmed from the inside without thinning them at the time of the insertion. So any irregularities, any bumps from the tissue surface of the dentures need to be removed. So this is on the day of the surgery, the teeth are extracted, the surgical template is used as a guide to see any pressure indicating areas, and if required suturing is done. And this is something called as a Burlew dry foil, which can be used to protect the extraction socket if there is a need to reline the immediate denture at the denture fitting appointment, so that any acrylic does not enter the extraction socket. So post-operative care is that the patient is told to expect some bleeding on the pillow during the first 24 hours post-extraction, and usually all the general instructions that you give post-extraction of teeth are to be followed. Patient is advised not to remove the dentures for the first 24 hours, because if he removes the dentures and does not replace them, then due to the edema and the swelling, the denture cannot be reinserted. So first 24 hours the patient will sleep with the dentures in his mouth. Frequent ice pack can be applied to reduce the swelling, and the patient is advised to expect some amount of bleeding. And after denture, uh, for all the other things like speech, mastication, and any other sore spots that may arise at the second post insertion visit, and they are corrected accordingly. And you check for the hygiene, whether the patient is maintaining proper hygiene, all these things. So in summary, immediate dentures fulfill an important role in today's treatment modality by providing patient with aesthetic function and psychological support immediate post extraction. The technique is more demanding than regular CDs for both the patient as well as the dentist. And if the patient is well prepared, the appropriate time of immediate denture is selected, and the resulting processes can be successful.